Hello, everybody, and good afternoon or good morning, depending on where you are in the country. My name is Garrett Schmidt, and I'm the managing editor for BBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by mPulse Mobile. And it is titled Designing Equitable Solutions to Increase Breast Cancer Screening Completions Across Diverse Populations. And this is a very important topic and something I'm excited to hear about from our speakers today, who I will introduce momentarily. A few items of note before we get started. This is a traditional webinar format, so all speakers or all attendees rather are in listen only mode, so you don't need to worry about muting your microphone or turning off your camera or anything. Don't worry, we can't see it or hear you, but we do want to hear from you. We're going to have a time for some Q&A towards the end. And at that time, we're going to get to as many questions as we can. If you have a question for either of our speakers or in general, go ahead and drop it into, there's a little question module that you have, and we're going to get to as many of those as we can during the allotted time. If for some reason we don't get to yours or aren't able to make it, someone will reach out to you via email afterwards. So, but without further ado, actually, one more thing before I introduce our speakers. Today's session is being recorded, and so what's going to happen is when we're done, you'll receive an email maybe an hour or so after the completion, and there will be a link to the recording as well as to where you can download the slides. And that way you can review it or share it with colleagues, and we hope that you do. But that said, without further ado, I'd like to introduce our speakers today. We have with us Ms. Srivani Ganti, and she is the Director of Health Equity with mPulse Mobile. And we also have Eden Brownell, and she is the Director of Behavioral Science and also with mPulse Mobile. So I believe, Eden, I'll pass it over to you at this time. Welcome.
Alrighty, thanks, Garrett. So hi all, so happy to have you here today. My name is Eden Brownell, as was just said, and I'm the Director of Behavioral Science here at mPulse. I'm coming to you live from Boston. My training is within psychology, sociology, health communication, and behavioral science. A whole bunch of things which boil down to the fact that I am a people watcher and I love learning about human behavior. My experience in digital health research and product design helps me appreciate the complexity of decision making in the real world, particularly when it comes to the tricky area of health and behavior change. A little further into the presentation, we'll discuss more about what the heck behavioral science is and how it can be used in healthcare. And today I'm joined by Srivani.
Hi, everyone. My name is Srivani Ganti. I'm the Director of Health Equity at mPulse. Eden is my partner in crime when it comes to developing these types of meaningful solutions that we're looking to talk to you about today. Also similar to her, Boston is my home, but I currently reside in Maryland. And my background is in biology and health communications. I'm really passionate about removing the ridiculous barriers we tend to put in place that prevent everyday people from understanding their health. I love using innovative channels to communicate and educate and empower people to take control of their health. And I like to take this a step further by reminding myself, my colleagues, our partners, our customers on the fact that healthcare really wasn't made to be equal and that there's a lot of work for us to come through together in order to do so. And I just love doing this because it reminds us that we need to center everyone, the people who are on the periphery, to help them achieve their optimal health. So with that, let's go to the next slide and talk to you about what we're going to cover today. So in our agenda, we're going to be understanding the state of breast cancer statistics amongst diverse populations, and we'll share how behavioral science and health equity address these common barriers, look at solutions that we can take moving forward, and then of course, open it up to all of you to discuss any questions and provide some answers that you may have. So let's go to our topic at hand on the next slide. So we know breast cancer remains to be the leading cause of cancer death amongst American women. And while cancer rates have slowly declined, there are still unfortunately barriers amongst diverse communities that prevent many of them from seeking timely and potentially life-saving screenings. So let's look at what these disparities look like amongst breast cancer screenings. I'm not going to read you all of the statistics on this slide, but I'm going to give you some highlights. So we can see here that Black women's 5-year survival rate for breast cancer is nearly 11% lower than white women. And women with disabilities are less likely to get any cancer screening due to various barriers, including accommodations for their disabilities, which results in a higher prevalence of these cancers. We also know poverty exacerbates any type of healthcare condition, right? And in this instance, poverty limits access to providers, transportation, fresh food, safe recreational activities, all of which are common recommendations given to people in order to actually reduce their risk of developing cancer. Hispanic women are 30% less likely to be screened compared to their non-Hispanic white counterparts. And this can be exacerbated by potential cultural beliefs that I'll be sharing on the next slide. And last, trans women and non-binary people who are assigned male at birth may have different screening criteria based on their usage of estrogen for gender-affirming care. Now, the reason why I share all of these statistics is to also create this reminder and grounding exercise that, first off, when we come to talking about health equity in diverse populations, it is also beyond race and ethnicity. Gender identification, ability also create a huge factor in individuals' access to care. So now that we have some of these statistics, let's take a look at what are some common barriers that individuals are facing. So what we did here is we broke it up into 3 different buckets. Now this isn't inclusive of everything that gets in people's way. We know it's a multifaceted problem, and it's not just cancer screenings, it's also with any type of healthcare access, right? So let's first look at health literacy. Unfortunately, there's a lack of understanding and clarity around breast cancer screenings and the options for genetic testing. Now, for many of us on this call, it might seem kind of obvious to us. We're like, yeah, of course we know there's genetic testing available. But that's the privilege we sit in. That's the professional system that we sit in as well, right? We also know that sometimes watching the news, it can be really confusing as to what are the recommendations for testing. I know myself, I enjoy watching the news, and sometimes I will see conflicting pieces of healthcare information. And for me, coming from a health communication seat, I think if I'm confused as someone who's trained in this professionally, what is someone else supposed to do? And we know mammograms are often stated to be the gold standard when it comes to breast cancer screenings. However, in recent years, there's some debate about their efficacy, right? And if that's happening, what are we supposed to do? If we as people who are within the healthcare system are a little confused about it, and we are engaged in depth in it, right? We are like immersed in it. What can we say for other communities that are not, right? When your profession does not lend to that area? And then, of course, there's this concern around the radiation, right? There are some people that unfortunately believe exposure to the radiation when you get a mammogram is going to lead to actual cancer diagnosis. And then we have cultural beliefs, which are really important. I think a lot of times it's a missed opportunity to understand the place in which a person is coming from when it comes to their healthcare. We know individuals are multifaceted, so beliefs are also multifaceted. And these I found were really interesting. Again, just a reminder, this isn't inclusive of everything, right? These are just some interesting points that I found through my own research. So one of the big ones is a strong sense of faith and belief in God as a form of protection, right? There are a lot of communities who have very, very strong faith and therefore are believing that, hey, if I'm praying to God, if I'm true to God, that's what's going to protect my health, right? And yes, that faith is incredibly grounding, can do powerful things, but we know screenings are important and life-saving. And then we cannot deny the long storied history of medical racism. We know that if you have historically seen your community mistreated century over century, decade over decade, it becomes very difficult to expect them to have a trust in the system. And then these were some 2 interesting ones that I had found through a study focusing on Hispanic women's beliefs when it came to breast cancer screening. And this one was, if lumps are pressed or touched, they can turn into cancer, or screenings don't even matter because breast cancer will kill. And those are really powerful things to correct with appropriate information, because we do know that when cancers are often caught early, they can actually lead to survival rates, right? You can actually survive it, you can thrive. Now, the last one I think is perhaps one of the most common ones and obvious ones to discuss, right? We know that SDOH, or social determinants of health, are really important when it comes to actually barriers in healthcare, right? social determinants of health, as we like to call it, SDOH, whatever you might be. So instances like finance, access to specialists, access to screening facilities, transportation support, accommodations if you do have a disability, if you are wheelchair bound, how is that going to be done? Access to childcare. Sometimes you also want someone to come with you. These are little barriers that get in the way that really compound themselves. So now let's take a moment to think about our problem on the next slide. When the barriers such as poor experience, lack of access and respect, and cost are coupled with conflicting cultural beliefs, it becomes increasingly difficult for us to expect breast cancer screening rates to increase amongst diverse, underinvested in communities. Now, at mPulse, we've thought about these barriers and have combined them with our engagement strategy. Through the power of behavioral science, health equity, and health literacy, we can create comprehensive whole person solutions, and we can remove barriers to increase breast cancer screenings in at-risk populations. So now I want to tell you a little bit more about what we're doing here at mPulse to look at whole person health with our proprietary engagement strategy. So my team is a content and creative services team, and we are in-house experts that are focused on bringing together these three strategies to create tailored and personalized solutions that are driven by behavioral science, health literacy, and health equity. I can't wait for Eden to share with you more about behavioral science because it's something that you are encountering whether you realize it or not on an everyday basis. We're really trying to think about what makes a person tick. And it's not just their cultural context, but it's how do we give them ownership? How do we make things easier for them? We also want to captivate and entice them through exciting health literacy. I think what we're seeing more and more in the transformation of health education, communication, and literacy is that it's not just merely words on a page anymore. It's not just articles, it's not just blogs. Visual media are a really compelling way to educate and empower people. We also are trying to overcome barriers in trust. And I'll be the first to acknowledge that I cannot solve for a history of medical racism and a poor relationship with your provider through a text message. But I can certainly do my best to try to give you the education and build trust and at least help you make informed decisions that you feel empowered by. And then last, we really like to think about behavioral barriers and think about what are the different ways in which we can work around them to make it a little easier. So let's dive a little bit deeper into two of these areas before I turn it over to Eden. So first, I want to talk about what is health equity. I'm sure many of you are aware of its definition, but for the sake of communication and clarity, I want to tell you this quick definition from the CDC. So health equity is the state in which everyone has a fair and just opportunity to attain their highest level of health. And at mPulse, we really knew that we couldn't actually tackle health equity for all that it is, right? If you don't mind going to the next slide. So health equity is a multifaceted, and it is something that is just, it takes everyone. It's going to take the entire village, the entire country to meaningfully address it. But what we did know at mPulse was like, there's a small areas where we can focus, and that's in digital strategies for member engagement. So what we decided to do was focus on 4 challenges within health equity. And we looked at social determinants of health, cultural competency, accessibility, and health literacy. And again, just a reminder, we know this isn't an exhaustive list and we know that there are so many other factors, but these were the 4 main challenges we felt we could meaningfully address through our engagement strategy. And in order for us to tackle these challenges meaningfully, we developed methods that guide our design approach, whether it be in SMS messages or animated videos. And these methods include compassion, data, dignity and respect, intentionality, inclusivity, cultural humility, and simplicity. We take such a methodical approach to guide our teams when it comes to our design ethos, because what I'm going to show you on the next slide is that we created this strict approach because we knew what the cost is in terms of money. So if you go and see, I think you have to click first. They're going to pop up slowly. Yep. So unaddressed health disparities, if we do not address them, are going to cost us almost $1 trillion by 2040. And when it comes to treating chronic conditions like cancer, it can rise up to $320 billion in healthcare costs, And this is only exacerbated in communities in which there is delayed diagnosis, and more often than not, those are racial minorities. We also know that ignoring health inequities means more people are calling out sick, which means significant amount of money lost, about $42 billion in productivity. And again, I know these numbers are really intense, right? Billions, trillions, that's a lot, right? But the Urban Institute does estimate that if we actually address health inequities, we can potentially save $15.6 billion. And we do know that money could actually go a long way in keeping our communities healthier. So now that we know a little bit more about health equity, I want to transition over to health literacy. And similarly, again, let's ground ourselves in what it actually means. Health literacy is the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. Essentially, what we're trying to say here is, how does someone find and understand health information and take appropriate action based on the information that they understood? So why on earth should we even care about health literacy? Well, fundamentally, when it's not addressed, it's a problem, right? Because we see here that nearly 50% or 90 million Americans lack sufficient health literacy. And there's a huge gap there, right? Because most people are reading at an 8th grade reading level or below. But the average health content is written for a 12th grade reading level. So how do we explain that 4th grade gap? What does that actually mean? What does that cost look like? So on the next slide, we can see the actual cost of what this 4 grades, that's essentially going from middle school to high school, right? What does that difference look like? Well, it's costing us a great deal of money. There's nearly $238 billion in annual costs associated with low health literacy, meaning there's a 4x increase in higher healthcare costs, 6% more hospital visits with almost 2 times longer stay, 2 days extra. That's incredibly expensive, right? Same, and you saw here, we still are throwing out numbers in the billions and the trillions for health literacy and health equity. And that's a huge problem because we know we do not have that money to burn. And we know our consumers don't have that money to burn. But also true to the topic that we're here, we'll show you on the next slide, there's also that we're seeing health literacy gaps that are inequitable too. As this graph is showing, we can see that the highest discrepancies and the highest gaps in understanding are amongst the Hispanic communities and those who are on Medicaid. And that's really not what we want to see here, right? We understand, so now how do we solve? So now that we know more about health equity and health literacy and how critical they are to finding a solution to the problem, let me turn it over to Eden, who will talk to you how these two will come together with behavioral science to create more equitable solutions.
Alrighty, coming off mute over here. The biggest struggle of 2024, coming off mute. So here we go. So before you can understand how mPulse designs solutions, it's important to define a few terms. So first, behavioral science. What is it? I talked a lot about it's my background. I'm a director of behavioral science, but what does that mean? So behavioral science is the study of human behavior. It looks to explain why people do what they do. If you've ever tried to change a habit, even for yourself, using your smartphone less or eating more healthy, you know that behavior change isn't always as simple as it seems. And people don't always act the way you predict. You might know that the cinnamon roll is going to make you crash a couple hours later, but you eat it anyway. But behavioral science is founded on decades of research. Scientists have a body of evidence that reveals the underlying mechanisms of how we act. They found that what drives behavior is often surprising. And that's why when it comes to making decisions about the products we create, it's so important to base our designs on this research. Next, we have behavior change techniques. mPulse designs solutions using behavior change techniques to help members take action for their health. Behavior change techniques, or BCTs for short, are strategies we employ when we design new products and solutions. There are many behavior change techniques based on behavioral science, as well as learning science and other areas of cognitive psychology. We've selected a few from that body of research that work particularly well in a healthcare context. And finally, get my click in here. Behavior change design, which refers to our process of designing effective science-backed solutions that are proven to improve health outcomes. That was a mouthful. But ultimately, when we make design decisions by going through the behavior change design process, we know we'll improve on the outcomes we're trying to achieve. All of this is important for organizations because if we can understand, predict, and change behavior more effectively, then we can make better decisions, which ultimately help members close gaps and drive better health outcomes. So, simply put, behavioral science points us towards behavior change techniques to design effective engagement solutions. All right, so we have our terms down. For anyone that might be furiously writing, we will be sending out these slides after, and we're also available at any time for any questions you might have as well. So just, I know for me, I'm always taking tons of notes. So next, our behavior change wheel. So that's what you're seeing in front of you here and really ties into what we just mentioned, but synthesizing the best of behavioral science, user experience design, and instructional strategy. mPulse uses these behavior change techniques to engage diverse health populations, change behavior, and meet health and business outcomes. So I talked about a lot of cognitive biases, behavior change techniques. Ultimately, behavioral scientists have identified more than 160 cognitive biases and behavior change techniques. They're growing every day. I think soon I'll probably have to name one like the Brownell effect and just join the club. But we've selected and emphasized 12 on the behavior change wheel because they are especially relevant in a healthcare context. They've been studied, they've been researched, and there's a lot that we can base our designs off of. Understanding how these biases influence health behaviors enables mPulse to improve population health and drive positive behavior change. So we have some of the basics, and now we will get into a little more as it relates to breast cancer screening. So today we can't cover all of the behavior change techniques on the wheel. We definitely can't get to all 160. So we've chosen to focus on the ones that we find to be very impactful when it comes to breast cancer screenings. So we're going to go a little into each of these. So first we have social proof. Show others how to do it. And so my good friend Aristotle, back in the day, once said, "Man is by nature a social animal." Let's forgive him for not mentioning women, but his observation holds truer than ever these days. Most of us are heavily influenced by what others do, think, or say, even though they are complete strangers. Think about TikTok and Instagram and things you're buying because you see it's from some person you're following. So this is all generally referred to as social proof, which is a term coined by Robert Cialdini in his 1984 book, Influence. You can see this in action everywhere. Things we buy, what we do, what we wear, what we say or don't say. Social proof is powerful, especially in ambiguous social situations where people are unsure about the appropriate mode of behavior and is driven by the assumption that others have more knowledge. So you're looking around, everyone's doing a thing. How can they possibly all be wrong? So that's social proof. Next, we have endowment effect, or give them ownership. And we don't only just have a sense of ownership when it comes to our possessions, we also feel we own our decisions, our ideas, our actions, and achievements. So with this in mind, it's important to personalize any outreach or communication to the member. We'll dive into examples of all of these after we finish covering these behavior change techniques. So next we have storytelling effect. Researchers and scholars alike have often written about the extent to which humans rely upon narratives for processing complex information, for entertaining and empowering people, and for communicating with individuals and the public more generally. So volumes of research have been devoted to understanding what constitutes the core elements of a narrative, how narratives affect human behavior, and why narratives evoke different responses than other methods of sharing information. It's been so researched that neuroscience got involved. So neuroscience imaging shows that facts and figures activate just 2 areas of the brain, those responsible for language comprehension and processing. But stories, on the other hand, activate up to 8 areas. So just like your brain's going all activated. And those areas that are activated have to do with touch, movement, scent, sound, color, and shape, in addition to language comprehension and processing. So ultimately, stories light up more the brain than factual reporting. And that's because storytelling connects listeners to the storyteller emotionally and motivates cooperative behavior. And finally, we have a spark effect. So we've left it to the end, but it is most definitely not the least important. Um, Eileen Halsworth, some of you on this call might know her. She's a fellow behavioral scientist and former behavioral scientist at Apple, which I'm sure all of you know are very much masters of behavioral science. Just look at their addictive technology. But she once said that humans are creatures of least resistance. We take the road most traveled or the road best paved. Um, so the spark effect really reminds us that humans are wired for the path of least resistance. Given several paths, we will pick the easiest, even when the easiest one takes just 20 seconds less to start. Seemingly little details in our environment create frictions that get in the way between our intention, so what we'd like to do, and our behavior, what we actually end up doing. Friction is whatever force slows us down or prevents behavior from happening. It's having to peel the orange and not just be able to eat it. It's the wait time. It's that one additional step or the difficulty level of a task compared to our skills. It leads us to either inaction or to choose an alternative action, an easier and often undesired option. So these barriers can be physical, social, situational, and oftentimes, even as we'll see with breast cancer screenings, psychological. Our cognitive biases and heuristics often operate as friction to desired behaviors. These are the barriers that design must overcome. So, with a little more information on each of these, let's actually dive into some examples and see how some of this works. So, here on this screen, you're seeing, we're going to show some examples of social proof and a couple other behavior change techniques. So one major issue with a lot of communications and things that we learned from Shivani today is the lack of representation, health literacy, messages that don't resonate with the population you're actually trying to communicate with. So one step we have taken at mPulse is to look at underrepresented populations and actually represent them in our messages. Here you are seeing different versions of one of our breast cancer screening messages with 4 tailoring options. Using race and ethnicity data that's gathered from plans, we will send these messages based on that information. Through these different messages you see here, trying to target some of those groups that we just learned about that have higher risk rates for breast cancer screening, we're trying to activate social proof. We want to emphasize that many eligible women do get regular breast cancer screenings and remind members that mammograms are normal and common among similar women. So how can we do that? We really want to make sure that they can see themselves and feel themselves in the communications that come out to them. And this isn't just our thoughts. Again, we said this really relates back to social proof, and it also relates to research that's been done on social proof and breast cancer screenings. So one study found that people who had learned that screenings were common behaviors reported increased intention to be screened, rated their probability of screening as higher, and were more likely to give their names and addresses to receive more information about screening. So social proof is really powerful when it comes to increasing screening behavior. We're going to keep going with some more examples here. Now let's talk about how we use behavior change techniques to overcome barriers. So as Shivani mentioned, there are a lot of barriers when it comes to health behaviors, especially one as tricky as mammographies. There are a lot of things, if anyone's even had to go get one. So our intentionally designed solutions really aim to uncover and address key barriers in order to activate members to take action that drive the health outcomes that we want. What you're seeing here is 4 of the top barriers to breast cancer screenings that we see across our programs, and therefore that we're primed to try to overcome. So within our solutions, we try to reach out to members. We try to understand if they have an intent to complete actions. We try to reinforce behaviors, talking all things behavior change design here. And then we know, just because of all the things we've discussed already, there will be friction, there will be barriers. How do we plan to overcome it when someone says, no, I'm not going to do it, or no, I haven't scheduled. And so that's when our barriers messaging comes into play. And so, like we said, these are some of the top 4 that we try to make sure that we are asking members if they're an issue for them, and then being able to provide solutions. So starting with the top, we see something like transportation. I don't have a car. So obviously, going back to what Shivani mentioned around social determinants of health, this is an access issue. They don't have a way to actually get to the thing. And so with an understanding of health plans, especially within Medicaid, having sort of a responsibility to have rideshare opportunities for members, we make sure that we work with plans to promote these key resources to members when this barrier is exposed. So we want to actually deliver the phone number they can call and let members know that they can have a ride. I don't think many people will understand that their health plan is willing to help them get to the appointment. And so that right there is just, again, going beyond, trying to understand health literacy, trying to understand that even until I knew that, we sort of overestimate who will understand sort of the benefits that are available. So we make sure that we put that in there and try to reduce the perceived effort of completing this. We also have things around motivation. So I don't need it. I'm really busy. Not seeing it as an important thing. So here we really want to empower members about why the screenings are important, and link them to motivational streaming to empower them to take health action. And so here again, we really want to lower the perceived effort of it. We want to make sure that members know that their plan is there to help them to complete it, and really try to increase the importance of this. That women are at risk. It's easier to treat when it's found early, and use the videos to activate storytelling effect and different areas, again, of the brain to try to up the importance of this. The next one is nervous or anxious. And after this, I'll skip ahead to the next just to be mindful of time, make sure we leave questions for everyone. But this one is very real. And I think for any of us that are maybe have to get one, the fear of something being found, or that the actual discomfort of the test itself. And so from research, we found that it's really important to break down sort of what a mammogram actually is, what it's serving, what it's going to do. We want to reassure members that they're not alone in this fear. So that's pulling on the social proof, coming from self-determination theory of relatedness. You are not alone in this. We understand, and therefore we've actually created this story or this video for you that's going to actually help to build their confidence around what a mammogram is and what it entails. And as we get through it a little bit, we'll show a little more of some of these amazing videos that our team has crafted. And then the last one here is around cost and affording. We just talked all about numbers and money, and healthcare is expensive, and it's not something that we all want to prioritize our hard-earned dollars on. And so for these, especially when it comes to preventative screenings, we want to make sure and work with our plans to make sure that's as clear as possible to the member that this is actually going to be a covered by your health plan. Where possible, we have used incentive language. If you're able to earn a $25 gift card for attending this, or something like that. We know that incentives can have a kickback, so it's not something we strongly utilize or have for long-term behavior change. But in instances like this, where we're trying to have a bit of a nudge, that is something that we have used with clients to help try to overcome a cost barrier. And so that was a lot of the barriers that we are sort of making sure that we ask members about if they say that no. But in addition, we are always listening for barriers. And so what do I mean by that? The mPulse platform utilizes NLU, or natural language understanding. another fancy word. But that's just a way of saying we listen to every member response, especially the unexpected ones, and use machine learning to handle them with pre-designed autoresponders. Again, a mouthful. So that might have sounded a bunch of random stuff. So what you're seeing in front of you is an example of someone responding to our initial screening message. And they might have said something like, I'm too busy to get this done right now, and then the response from our system. So within this message back, we're trying to relate to the member's concern. We want to use spark effect in order to, again, reduce the perceived effort. We have things like in 20 minutes, you can care for yourself. We have words like, it's easiest to treat, those type of things that are going to trigger things in the member's brain. We are really trying to lower what they perceive to be the effort of this. And then also we have at the end, we have a video that will utilize storytelling effect and endowment effect to overcome the barrier the member has brought up. So that is a sample of, one instance of our system listening, hearing a barrier, and being able to respond to it in the moment when the member has actually showed that barrier. And so speaking of storytelling effects, as we said that this ends with that storytelling, let's touch on a few more examples of that before we wrap up today. So good. These are playing. I was worried they wouldn't. I'll click on the second one in a minute. So as we mentioned earlier, stories are powerful. They are activating all those different parts of the brain and tapping into emotions. What you're seeing on the screen here is 2 examples from our breast cancer screening solution. Why did we use stories? Again, because of the power, but also as it relates to breast cancer screening. Research shows that members are motivated to schedule and attend breast cancer screenings when they hear from others willing to discuss sensitive topics. And they also, when storytelling is done in a culturally and linguistically appropriate manner, it encourages diverse groups of women to schedule breast cancer screenings because they learn from the experience of peers like themselves. So at mPulse, we use photonovellas to build confidence, overcome barriers, and empower members to schedule their breast cancer screening using streaming content. Something that we didn't mention, but is really relevant to the storytelling piece, is just like we show different tailoring based on if someone comes over as Hispanic or Asian, and these different groups that we really want to make feel represented. We've also changed out in a number of the videos. We haven't shown all the different versions here, but who's the main character of that story, and how can we use visuals that actually make the member feel represented in that story when they're talking to their doctor, when they're getting a mammogram. So there are different pieces of the stories that, based on the audience and that data that we receive on race and ethnicity, that will change to be more reflective of the population we're speaking to. So we are trying to do a lot within these stories. You can do the QR code if you want to have one of these to look at after. And really, I could go on and on about the power of storytelling, but for the sake of time, we're going to wrap things up and end with a review of some recommendations that you can use now to improve your breast cancer screening campaigns. So, as you learned from today, breast cancer is a major cause of illness and death in the United States that disproportionately affects low-income and racial and ethnic minority populations. Today, and in front of you here, we have suggested a set of enhancements to existing strategies using behavioral science, instructional strategy, and health equity in efforts to increase cancer screening in underserved populations. Many of our suggestions with respect to the framing of choices, using social proof, message delivery, could be added and evaluated within existing systems with little cost. Most of what we talked about today were changes to content. And so just being able to take the power of the 4 behavior change techniques we discussed and immediately be able to think about ways you can apply it to your own campaigns. So the challenge ultimately of reducing and eliminating cancer-related health disparities is formidable. But we believe using tools from these various disciplines, it may move all of our efforts forward in meaningful ways by taking a realistic approach to human behavior and decision making. So we're going to leave you here with this. We've sort of tried to do a too long didn't read version of the PowerPoint. So if you end with anything, we've pulled this together here. It's going to highlight some of the things that you can apply to your campaign. And with that, Shravani, do you have anything you'd like to say as we wrap up before we go to questions?
I think just kind of reminding you what Eden was saying is that also another thing to take away from this, and it might feel like a lot, and you're like, I don't know where to begin, is think about who you're bringing to the table. I think that's a really important factor. Is you don't need to feel responsible for solving it all. And none of us should feel that because we all have our own unique perspectives that are essentially singular to our own, right? So make sure whomever you're talking to about this has a different perspective from your own, have different ideas. Research only goes so far, but firsthand accounts from people that you're trying to connect with who are directly impacted can be far more impactful. They're people at the end of the day. So treat them with that dignity and respect, honor their time. If you're doing focus groups with your membership, your patient population, reward them for their time because they're taking that out of their day. So again, just really for me, don't feel like you have to go it alone. Ask people for help because we're asking people to ask for help as well. So don't be shy in asking for help as well.
I ask Shravani for help all the time.
We
So
both are
anyway,
on each other for help.
here we go. We're going to hop into sort of the open forum, questions and answers. I think Garrett kind of pulled at some of this. You can put these in the chat, and Garrett will come back to us.
All right, here I am. Yes, I'm back. And actually, yeah, you do have a little module at the top just for questions. So go ahead and drop your questions in there. And we're going to get to as many as we can today. First question is this. What metrics will be used to assess the program's success in reaching and serving diverse populations equitably?
Yeah, of course. Shravani, do you want me to hop in on this one?
Yeah, why don't you go ahead?
Perfect. So for metrics, we're all interested in that. So we did sort of do a little peek of how we are getting data from plans. So we want to be able to first get race and ethnicity data. And then what we do at the end of the program, we use that to tailor, to personalize content. And then at the end, we use that to actually then break out the data to understand how did members within these groups actually respond to communications in the hope to then improve them. And so part of the metrics that we use are going to be things that are standard to engagement programs. Are members, responding? Are they engaging? But like we said, we sort of hinted at some of our key messages that are in there. So we're looking for members to actually, do they have intent to schedule? Did they schedule when we asked if, they were able to reinforce their responses to key barrier questions? So all of these things can then be broken out and segmented by race and ethnicity. So you can actually understand even within your population, within segments of your population, what barriers and responses are really coming up for them.
Great. And next question is, how will feedback from participants be collected and used to improve the program?
Yeah, I think I can go this, and then Shravani, you might be able to add to it as well. So we talked a little bit about natural language understanding, our machine learning, our cool tools that sound really cool. And I don't have an expert in house to talk about really how they work, but the sort of magic that I see from them is that because our system is always learning, we're always taking in member responses. That is one source of feedback for us. So I said we're always listening, especially for the unexpected responses. And that's because, like we said, behavior is unpredictable. And what members are saying back to us can actually key us in to other barriers that they're experiencing that we didn't think about. And so that allows us to iterate on the solutions that we design and then build those back in. And so things like, in an initial solution, we may not have accounted for something as relevant as I had a mastectomy. I already have breast cancer. I am currently in remission. So taking those responses and actually creating really empathetic responses back and or connecting to plan resources. So that's one way that we're really using our platform to take it in. And then we also work with plans where possible, where they're interested in really partnering with it on us is doing surveys to their populations, working with them on actual how do they engage with content, and then doing A/B tests as well. So we actually want to test which one seems to be more relevant, breaking it out by those demographic data that we said. Do we see different improvements or different messages that work for one group or another, and then being able to proceed in that way. So we are definitely trying any ways that we can to get our hands on actual member feedback and just information on the population.
Great. Next question is, how will the program address language barriers and provide information and services in other or multiple languages?
Yeah, I can go ahead and take this one. So one of the things that we do, because especially most of our customers within mPulse right now are Medicaid, we try to do compulsory English and Spanish just to make sure we're addressing the population needs. However, we are also able to translate into over 150 different languages. So we're able to accommodate quite a few, as you can imagine. And then also with our natural language understanding, we've also built in, I think, about 7 languages in total to be agile to the responses that members are saying. We obviously don't do all 150 because those are not necessarily common requests that are coming our way. But English, Spanish, I think Chinese, Tagalog, just a number of different languages that we're able to accommodate. And we also have something called a language switch. We have that built in both into our SMS and IVR programs, where if the member wants something that's not an English language and we don't have that field in their data file, they can switch into a language that's available. More often than not, that's usually Spanish, but if we have a customer who's interested in other languages for their population, they can do that as well.
Yeah, great. That's very important in this very connected world. Okay, next question is this. Is there an age factor with respect to members' response rate to messaging?
So I think we probably can tag team this. I think a lot of people are probably wondering, do older people text? And the answer is yes. We actually see pretty favorable results amongst older populations. So people who might call them quote unquote baby boomers, Medicare populations, they're texting, they're interacting. I don't think we've observed a lot of confusion. I know some of us are thinking, well, then why can't my parents set up like whatever WhatsApp on their phone? That I can't answer for you. But we do see all age groups that we're able to reach out to engaging with our platform. It's not prohibitive. People have smartphones. I think Pew estimates around 85% of Americans have smartphones. So that's included of older generations. So if you're worried about them, I'd still encourage you to try. Like if you think your population is too old, I doubt it. I doubt that they're too old, and they are engaging meaningfully, and that is relevant to especially breast cancer screenings.
And one thing I'll say is we like to do omni-channel. So we're sort of, like Shivani said, we see such a mix of generations, how they're responding. Even in my own life, I just like my friend's husband was just saying he ignores his text messages. If you looked at it, for anyone that's OCD, he had over 3,000 text messages unread. And he tells people to email him. This is someone who is 30, and I'm like, well, that doesn't seem to fit your generation profile. But that's the thing about generations and personas. We really can't, always predict where people are going to best communicate. And that's why we utilize both SMS, we use email, we use IVR, and we try to teeter our approach on how we actually send out the messages. So we like to use SMS because it allows us to use some of the more like the things that we discussed today, some of the barriers analysis, the storytelling, the videos, but we see really great engagement with IVR and email as well. And so we mix it in based on how we're seeing members engage with the program.
Yeah, no, that's great. Okay, and this next question here, this is a good question. How often should breast cancer screening be scheduled? Annually?
Oh, I think family history is a huge depending factor. I'd also say, again, similar to the example that I gave earlier was like with individuals who are trans women or non-binary assigned birth male at birth. That recommendation may shift based on estrogen use and the length of time. I think so. We use the HEDIS metric again because most of our customers are within Medicaid. I believe it's 2 years, but honestly, Eden and I are not doctors, so you should definitely talk to your primary care provider to get, if you're wondering your risk factors or screenings. And if you're at that age, 45, 50, you should probably get screened. So recommend calling them. But those are the recommendations that we typically go based on. So family history, NCQA HEDIS metrics tells us about every 2 years, but you should really talk to a actual medical provider instead of two lovely public health individuals to confirm that information.
All right, and I think we lost our slides.
Yes,
I think
I
so. We have a nice calming green, rolling green hills in the background.
Yeah, that's right. At least it's a pleasant scene.
I was going to reference our doc. I am not a tech wizard, so I'm getting back in here now, I think.
We see it. We can see the regular PowerPoint view, but I don't know if there are any other ones.
Yeah, it's.
There we go. There we go. Yeah, we're working live, folks. So
we're working live. She's not a tech expert.
She works in tech. Thankfully, not in PowerPoints. Actually, we only have PowerPoint.
Exactly.
It's okay. We're gonna figure it out. I'm gonna go.
Well, no, this is great. Yeah, thank you guys so much for these questions. If you do have an additional question that you would like to ask, you can go ahead and drop that in at this time. And if I think we're going to have to probably close out here, but someone will get back to you via email afterwards. As we're closing out, I know that you guys wanted to talk a little bit about the Activate conference.
Yeah,
and I'm dropping a link in here to the chat.
Thank you so much. So this is probably one of our, flagship events at mPulse, our Activate 2024 conference. We're holding it in Dallas this year. We're really excited. And this is becoming a larger industry event in which you can really come and learn about the intersection of technology and healthcare. And we would love, if you're interested, to please reach out. I think if you go to the next slide, you can see, we can share what our topic is, which I believe it's more focused around consumer journeys. I think PowerPoint's tired of us today, apparently. Not kind, but from insight to intervention, creating consumer-centric digital experiences. So it's very fitting for the conversation that we're having with you all today, because we want to focus on the consumer. Again, healthcare shouldn't be happening at a person. It should be happening in collaboration with them. And that's how we're going to explore in this conference. And Eden and I have been attending for the past couple of years. We present, we run sessions, and we really enjoy it. And it's just a great way to meet people from across the industry. So please check us out if you're able to join in September.
Great. How many years have you guys been doing that?
Oh, goodness. Probably like 6, maybe.
Yeah.
I feel like we've been doing it since the late teens, at least. I don't know off the top of my head, but Eden and I have been going we've been there for the past couple of years, and we've always really enjoyed ourselves.
Nora just chimed in and said 7 years and counting. So
there you go. Yeah. See? Yeah.
Very good. Well, yeah, definitely. I've heard great things. Check it out if you can. As we close out here, though, again, I want to thank our speakers for today. And I wanted to encourage you all to check out the mPulse mobile virtual exhibit booth on VBC Exhibit Hall. If you head over to vbcexhibithall.com, or if you follow the link in the slides, you'll be able to find their booth. There's a lot of great resources there. You can see what they're doing in the space, ways to reach out. There's also just a lot of great general educational things and webinars and articles and all sorts of stuff that you can access there for free, and it doesn't cost anything. So would love to have you come over and visit us. And then finally, if you would like to reach out to either of our speakers today, their contact information is here on the screen. And so, again, we're going to be sending out a link afterwards to where you can get the recording and the slides. So all of this will be there. But feel free to reach out to them directly or reach out to me, and I'm happy to facilitate an introduction if you'd rather go that route. So thank you all again so much for joining us. Thank you both for a wonderful session. Hope you join us for the next one. Have a great rest of your afternoon. Bye-bye.
Thank you all. Bye.